Welcome back to another Provident webinar. I'm your host, Ed Mann, Director of Training and Education. Tonight, I have the pleasure to introduce Dr. Marc Cruz, the Vice President of Research and Development for First Responder Behavioral Health. I had the pleasure of meeting Dr. Cruz last year in Memphis during a workshop with the First Responder Center for Excellence on incorporating behavioral health screenings into annual physicals. To say I was intrigued to learn of the work he has done with veterans and first responders is an understatement. So much so that I asked him in August of last year if he would participate in a podcast and webinar. And as they say, the rest is history. As I learned during our podcast with Marc in January, first responder behavioral health goes much further than PTSD. I'm hopeful we'll have plenty of questions, and we're asking you to use the question and answer feature to send your questions. We will make every effort to answer all of them. However, if we don't get to your specific question, we will get answers to you via email in the days following the webinar. In a few minutes, I'll have Dr. Cruz introduce himself and give you some background on his organization and himself. But beforehand, I need to introduce you to the company that is sponsoring this evening's event, Provident Insurance. Provident's been around since 1902. They were incorporated in 1902 as a private independent insurance company in the Pittsburgh area. In 1928, they began serving volunteer fire departments with customized blanket and accident and health policies. We have insurance policies in every state in the country right now. Today, we provide volunteer, combination career firefighters and emergency medical responders with a multitude of programs. We also offer special risk and transportation insurance. Provident, celebrating its 5th year in a row, is being voted as one of the top insurance businesses by the Insurance Business magazine. The programs that we offer to first responders: our accident and health program, which includes access to our 24-hour first responder assistance program that is not only available to their first responder, but also to their immediate family members. We have a 24-hour accidental death and dismemberment insurance policy, a group life, critical illness and cancer policy, Fire Plus, which is our property and casualty insurance. And if you have your property and casualty insurance with us, you're entitled free of charge to be able to use our online training platform called the Fire Plus Academy, which is actually hosted by Fire Rescue One. Tonight, as I said, Dr. Marc Cruz is with us to talk about more than PTSD, behavioral health needs of first responders. I'm going to stop sharing my screen and turn things over to Dr. Cruz.
Thank you, Ed. I really appreciate the opportunity to talk about what we're doing and share what we're doing with your audience. So I'm going to try to share my screen. And we can get started. Okay, great. Thank you very much. The title of my talk is It's More Than Just PTSD. What the data actually tells us about the behavioral health needs of first responders. And just in terms of kind of background, so I've been working with this company, First Responder Behavioral Health. We started back in 2018 is when I was initially approached to develop an online behavioral health assessment and feedback tool for first responders. And in terms of kind of why they reached out to me, in terms of my other background, I've served as a staff psychologist for both Austin Fire Department and Austin Travis County EMS dating back to 2011. Before that, I worked at the VISN 17 Center of Excellence for Research on Returning War Veterans for about 4 years here in Central Texas. And so, some people oftentimes ask me, like, why did you kind of get interested in this and start doing this work? And it's really based on the fact that I think we have a shared responsibility to really proactively try to address the behavioral health needs of our first responders with the goal of really trying to minimize the potential negative consequences of a career in public safety. one of the things that we know about first responders is the work that these folks do for our community. One, it's something that not most of us can do. And two, despite its tremendous rewards in terms of the opportunity to serve other people, it can come at a potential cost. And so I think if we acknowledge that fact from the beginning, it puts us in a position of kind of obligation as fire service leaders, as fire chiefs, as behavioral health professionals who are dedicated with working with first responders to do all we can in order to try to minimize the impact of this type of a career. So a little bit of historical stuff. As many of you know who are logged into the session today, behavioral health was something that we didn't really talk a lot about prior to really kind of in the aftermath of some of the big disasters that we've had in our country. And whether it was the Oklahoma City bombing, certainly the terrorist attacks on September 11th, Hurricane Katrina and Hurricane Rita, and some of the other hurricanes that devastated some of our coastal communities. But for a long period of time, the behavioral health aspect was something that was just kind of ignored, right? Maybe it was talked about kind of in dark corners, but certainly not very openly. And one of the things that came out with the Wellness Fitness Initiative, their fourth edition, which came out in 2018, is that, we've been taking care of people's physical health needs for a while. And we really need to make sure that we're starting to look at the behavioral health evaluations as well. And so this was kind of the first time that the fire service industry really came out and said, we need to make sure that we're checking on our folks really every year. And they suggested that it was part of the annual medical evaluation and wanted to look at all sorts of things, whether it was related to substance use, how people are dealing with stress, but also family issues as well. And the whole idea behind this was, we want to connect our first responders to really behavioral health specialists in a way that we can identify kind of what resources are needed, with the goal of really trying to make sure that we are preventing behavioral health difficulties from becoming life-altering or career-altering situations. And as they pointed out at the end, this is really only going to work if privacy is ensured. Well, fast forward from this kind of global kind of positional statement in 2018, which was really the first time this was thrown out, to now what is the standard? And so in 2022, NFPA released the new standard, and now part of the physical standard, section 7.7.26, is that part of the annual medical examination really is supposed to include a behavioral health screening. And they point out some key features, right? One, we've got to make sure the screening assessment, it's non-diagnostic, it's designed to identify risk. It absolutely has to be confidential, and it can't be used to remove firefighters from service. They really talked about the emphasis on using validated self-report assessments. They suggested that we look at post-traumatic stress, depression, and substance use as the three areas that they're required to be evaluated. In our world, working with first responders day in and day out, I think there's a lot of other things that we should look at as well, and that's kind of what our system does. And then ultimately the goal is, when it's appropriate, we want to make sure that we're getting the first responder connected to a qualified professional. So with those kind of things in mind, we created this program back in 2018 with kind of 8 essential kind of goals. So the first thing was we wanted to make sure that we were using gold standard screenings from the standpoint that if we're using a screen assessment and a first responder utilizes it and they take it to their medical provider, we want the medical provider to be familiar enough with it that they can actually provide some meaningful feedback for folks. And the little plus that's on there too is because of the way that we've designed the system, we're not just having people fill in bubbles on a sheet of paper that gets turned in. We're able to kind of go that extra step, and I call it the choose your own adventure kind of style, for those of you who remember those books back in the days. But based on kind of your initial questions, we're going to ask some follow-up questions that are going to be relevant, or we're not going to ask follow-up questions if they're not relevant. We think it's really important that just like physical health is more than just the absence of cancer cells in your body, physical health incorporates things like physical endurance, muscular strength, cardiovascular fitness. we know that behavioral health is more than just the absence of symptoms of depression, right? And so we want to make sure that we're getting a full picture of the first responders. So we're looking not at just symptoms of psychological stress, but we're also looking at things like relationships and resiliency and coping strategies in order to make sure we're getting a more full, complete picture. We think it's really important that if we're asking information out of the first responders, that the most important thing to do is that we're providing relevant education and feedback, right? We're not just trying to get information, we're trying to utilize that information to give something meaningful to the first responders. We also think it's important to track changes over time. One of the things is behavioral health is a little bit like weight gain, and that it happens kind of slowly. I'll go ahead and out myself here. I've gained on average 1.2 pounds for every year that I've been married. But the good news is, like, well, that doesn't seem like too bad from one year to the next, right? But over 21 years, that starts to add up. And so at what point did I get a little too heavy, right? Somewhere in the 20 teens maybe is where that point was for me. But behavioral health is kind of the same way. So at what point do we kind of go from our kind of normal version of ourselves to becoming a little bit darker, to becoming a little bit more jaded? And oftentimes this doesn't happen overnight. It's a gradual process. And so if we're able to track changes over time, then we'd be able to recognize changes over time and try to intervene early in order, again, to prevent us from getting to those difficult spots. We think it's really important that the whole goal of this is that if we have a first responder who's experiencing difficulties, our goal is to get you connected to your appropriate resources, right? So you can get the help that you need. We've had a lot of people who worked really, really hard to develop some really effective treatment programs. And we want to make sure that our first responders have access to the state-of-the-art treatment programs that are going to really help them. We think we have an obligation to take this information that we're getting and really promote both department-wide as well as public safety industry wide changes. We have a real obligation to make sure that we're addressing what can we do at department levels, what can we do service-wide in order to make things better for our folks, and things like this talk today helps that. Our goal is to protect first responders. And in particular, our goal is we want to save lives, careers, families, and marriages. We want to make sure that our first responders are able to take this in evaluation where they're not worried about their job security because the information is going to be protected. That when you have the opportunity to review this information with a physician or a nurse practitioner or a psychologist or whoever, that they're able to take this information and help make things better for you. So I'm just going to very quickly kind of walk you through what we do. We have 8 different assessments. The first one is kind of basic demographics, where we get things like age and years of experience and race and ethnicity, and whether you're a volunteer or career first responder, whether you have secondary employment, all those types of information. And then we cover the big 5. And the big 5 for us when it comes to behavioral health are depression and anxiety. And when we talk about anxiety, the type of anxiety that first responders tend to experience the most is really called worry-based anxiety. We don't have a ton of first responders who are struggling with panic disorder or social phobia, but that worry-based anxiety is kind of what a lot of our folks end up struggling with over the course of their career. We look at substance use, both alcohol and tobacco. We evaluate symptoms of post-traumatic stress, and we measure sleep. And as you'll learn today, it turns out sleep is really, really important. I mentioned earlier that we talked a little bit about the positive psychology, and so things like social support, resilience, coping, satisfaction. And then the last little mini survey that we have, we talk about behavioral health, and I'm going to share some data with you in terms of what percentage of our folks are aware of behavioral health difficulties or actively treating behavioral health difficulties, and if they are, kind of how effective are those services that they're using, and if they're not, what are some of the barriers that get in the way. So our whole goal is we really want to provide information that's relevant to the first responder. And so our system is kind of unique in that we provide 3 different layers of feedback. And the first and most important is we provide a lot of information to the actual individual first responder. In addition to a brief little summary thing that kind of shows how you do relative to other first responders in both your department as well as our national average, we provide a much more intense and kind of thorough feedback report related to each of the big five. And we spent a lot of time on those things, providing education, providing information that's able to kind of help people understand what they're going through and then get connected to resources. One of the huge benefits that we've had from this assessment from people who have gone through is that some of our folks have come back and told us like, hey, you know what, I'm not experiencing depression, but I think my significant other is. And so when I went and I read that kind of feedback report and I learned about that, it was able to help my get my significant other into treatment. And so that's kind of a really nice kind of thing we're able to do. The second level of feedback that we provide, again, because this should be part of your NFPA 1582 physical. And even if you don't get an NFPA 1582 physical, we want to make sure that we give you some tools that you can use to go to whoever your individual provider is in order to kind of help with things. And so the information that's contained in the provider report is it's basically just the standardized assessments. So they don't get all the nitty-gritty details that we provide you in your reports, but they get screening status, you know, what's your standardized score? And again, we want to compare you to other first responders. If they look at our norms and they compare our norms to a sample of, for example, elementary school teachers or accountants, they're not really going to get a really true sense of how are we doing compared to other first responders. And again, one of the goals of that is we want to be able to track changes over time. In my world as a psychologist, usually when I think of high scores are considered bad, right? And so high depression symptoms are usually pretty bad. But one of the things that's very evident about working with first responders is we like high scores as first responders. And so high scores are good. And so as you can see on here, it's really very easy to see that the person on the left is doing significantly better than the individual on the right. We do all sorts of little color coding schemes in order to kind of make things happen, where you can see the individual on the left side of your screen, their scores are in the green, which is great. And the individual on the right, their scores are a little bit further down. So we really try to make it really kind of basic for them. And then our third level of feedback, again, because we're really trying to promote department-wide changes and really challenge departments to do all they can to make sure that they are addressing and taking care of the behavioral health needs of their agency as a whole. We provide the summary kind of aggregate data that never identifies any single individuals. But what it does, it allows us to see like what are kind of the big issues that are going on in our departments. When we provide department presentations, we very much believe that it's important that these department presentations are available to all employees, right? For one thing, we want our first responders to be aware that we're not providing anybody's personal information on this. We are really looking at this aggregate summary data in order to look at what are the department-wide behavioral health issues. It provides a checkpoint relative to other public safety agencies. And what it really allows our kind of administrators and our funding sources to do is to see, you know, how can I allocate resources in order to address the real issues that are going on. You know, we've had several of our departments who've used this data to go out and support behavioral health initiatives, whether it's hiring a behavioral health professional or establishing a contract with someone in the community to make it a little bit easier for our folks to go and see someone. Other people have gone and actually used it to apply for safer grants to receive funding for that. So we're pretty excited about that. And so as we kind of walk through some of this stuff today, I want you to all kind of think about these questions, right? And this is where the power of aggregate data really kind of comes in. And so if you think about your department, I want you to think about what are some of the biggest behavioral health issues that you face? And really, how concerned should you be about these issues? A lot of people are really interested to know how does their department compare to others, right? You know, we do 6 a.m. shift change. How does that impact us compared to someone who might do a 7 a.m. shift change or a 10 a.m. or noon shift change like my department does? To what extent are our first responders utilizing resources that are available? I've had a lot of departments that I've worked with talk about, well, we pay for this EAP and we you know, get that information kind of all over the place, but we don't really know if anybody's actually going. And so are people utilizing these resources? And if not, what are some of the barriers that get in the way? And if they are these resources actually effective? I had one of our departments say that they were paying a significant amount of money for an EAP. And when we did this assessment, we only had 3 people in their whole department report that they had gone to the EAP in the last year. And they were able to go back and actually verify this. We didn't tell them who the 3 people were, but they were paying a lot of money for a system they weren't actually going to benefit from. And so they were able to go to the EAP and say, hey, we'd like to get you more involved, and we'd like you to address some of these issues for us. And so what kind of programming can you put on? Again, we think it's really important to challenge the departments to figure out, what kind of department-wide interventions can be made. Do we have policies in place that actually discourage people from getting help? Do we have policies in place that prevent people from getting as much sleep as they're able to? And then ultimately, how can we use this information to help our first responders, both as a whole, as well as individuals? And so what we're going to be doing today is I'm going to kind of walk you through, what does this kind of aggregate data kind of look like, and what are some of the things that we're learning? So I'm going to actually share with you the data that we get from our national sample to figure out to what extent are our first responders struggling with each of these big 5 conditions. And then as kind of indicated there, we're going to spend a lot of time talking about the impact of impaired sleep. And then share a little bit more data with you, and then hopefully have time to answer your questions today. So, so we already kind of talked about that. Going backwards a little bit, sorry about that. And so in terms of our national sample characteristics, we are now in 15 different states. We start in the state of Texas, which is why that's highlighted in blue, and we've expanded primarily through word of mouth from different departments and different presentations that we've given. In terms of our national sample characteristics, not surprisingly, we're about 95% male, which is pretty consistent with at least fire service as first responders. The vast majority of our folks self-identify as white or Caucasian, with Hispanic or Latinos and Black and African Americans making up the next 2 populous groups. Our average first responder is about 40 years of old, with about 11 years of fire service experience. Not surprisingly, almost 2 out of 5 of our first responders report that in addition to their job serving their community as a first responder, they also have a secondary employment. About 1 in 6 of our folks report that they've served in the military, and about half of those report that they've been deployed to a combat zone. And about 90% of our first responders report that they're currently in a committed relationship. Now, the joke that I say here in front of our live audience is that there's no guarantee that this is the same committed relationship that you started your career as a public servant in. But our first responders tend to stay in pretty committed relationships as we go from there. Okay, so I'm a huge data dork, and let's get into the actual data. And one of the things that we find is that about 1 in 4 of our first responders screen positive for depression. You can look at the specific symptoms along the side to the left. Not surprisingly, especially given the shift work that our folks tend to work, 60% of our folks report that fatigue and loss of energy is their primary symptom of depression. I had a client in my office the other day who was reaching out because he had put himself on testosterone, thinking that some of the things he was going through were related to low T. And when he went to one of these clinics, his testosterone levels were kind of, they were above that threshold where it's considered low, but he decided to go on testosterone anyways. And sure enough, here we are a little while later, a couple of years later, and that didn't address the issue. And as we started talking, as he started relating what he was going through, what he was really kind of representing was that a lot of the difficulties he was experiencing were really the symptoms of depression. And in his particular case, working at a very busy station for a long period of time, they were probably impaired sleep-induced symptoms of depression. And so as we kind of go through this, we can see that most of our fire apparatus at least have 4 folks who are on it. And so if we extrapolate, about 1 in 4 of our first responders are screening positive for depression. When we look at worry-based anxiety, again, that's the type of anxiety that our first responders are most likely to screen positive for. Once again, we see about 1 in 4 screen positive for that. Now, interestingly, although there's some overlap, there are a lot of different people than the folks who are screening positive for depression. And not surprisingly, especially for those of you who might be significant others, the first responders, the symptom that they report being the most kind of bothered by was actually irritability. When we look at substance use, and I'm going to talk about alcohol use today, we get about 1 in 6 who are screening positive for being at risk for an alcohol use disorder. Now, you might see the red letters there that suggest that 10% report they haven't had any alcohol in the last year. And again, when I'm speaking in a room full of first responders, I say, what do we call those people? And hopefully at least one person right now is typing in the chat box. Liars is usually the response that I hear, and everybody gets a good chuckle out of it. But in truth, we do have about 10% of folks who report that they haven't used alcohol in the last year. Now, the reasons for that actually differ. Granted, we have some people who might not feel comfortable answering honestly on these surveys, which is important for us to keep in mind. But we have about 10% of those folks, so a little under 1% of the sample, report that they're currently in recovery from an alcohol problem. We get about 50% of those folks, so about 5% in general, report that they're lifetime abstainers. And then we have another 4% who report that they've consumed alcohol in the past, but they just didn't in the last year. And so that could be everything from a first responder who's trying to get pregnant, or maybe their significant others trying to get pregnant. They're being supportive, to people who are doing it for health issues or weight issues or whatever. But when we look at it, we get about 1 in 6 who are screening positive for being at risk for an alcohol use disorder. Now, this is where we get to the kind of the title of the talk, that when we look at first responder behavioral health, we need to be addressing more than just post-traumatic stress. And so about 1 in 20, so about 5% of our first responders endorse symptoms that are consistent with the possible diagnosis of post-traumatic stress. And again, these screeners, they don't diagnose, they just identify to what extent people are screening positive for that. But for those departments that are focusing all of their resources on exclusively dealing with post-traumatic stress, I think we can make the argument that we might be missing out on some of those other issues that folks are dealing with. So we've gone through the first 4, so about 1 in 4 for depression, about 1 in 4 for worry-based anxiety, about 1 in 6 screen positive for alcohol use disorder, and about 1 in 20 screen positive for post-traumatic stress. And then look at this. When we look at what percentage of first responders are screening positive for impaired sleep, that jumps off the board, right? So these aren't just first responders who are saying, yeah, I wish I could sleep a little bit more. But 45% of us are actually meeting that threshold that if you filled out this form in your doctor's office, it would kind of give them the authority to order a sleep study, to provide kind of interventions, and whether they're pharmacological interventions or other types of interventions in order to kind of address our sleep. And so here we're starting to see, what might our biggest behavioral health issue be. Right. So compared to the general population, this is what we see. Impaired sleep tends to be the biggest thing that's going on. Now, overall, 57% of our folks are screening positive for at least one behavioral health condition. And as we go down, it's all the way down to about 1.5% are screening positive for all 5. But again, I'm going to make the argument and try to back it up with data that perhaps when we look at what are the biggest behavioral health issues affecting first responders, it makes sense to start with impaired sleep. If you pay attention to no other slide except for this one, I hope you pay attention to this slide. And so the column that's up there right now looks at what percentage of our first responders who aren't meeting that criteria for impaired sleep, what percentage of those are screening positive for each of the other big 4. And what I'm going to pull up there is I'm going to show what happens to that percentage when we compare the not sleep impaired first responders with the sleep impaired first responders. And so your likelihood of screening positive for depression goes from 7.5% to almost 50%. That's a factor. You are 6 times more likely as a first responder to screen positive for depression if your sleep is impaired than if you don't have impaired sleep. Your likelihood of screening positive for worry-based anxiety goes from 9% to 43%. So it's almost 5 times as likely. to screen positive if you have impaired sleep. Your risk for screening positive for an alcohol use disorder more than doubles if you have impaired sleep. And your likelihood of screening positive for post-traumatic stress is 12 times higher if you have impaired sleep. And so overall, our first responders' likelihood of screening positive for any of those behavioral health conditions goes from 1 in 5 to 3 in 5. So you're more than 3 times as likely to screen positive for a behavioral health condition if you have impaired sleep. Not surprisingly, then, if we start looking at how do our first responders with normal sleep, right, who don't have impaired sleep, they're the ones in the blue, and if we compare their behavioral scores with the first responders who with impaired sleep, those bars in black, you can see that we're scoring lower across the board, even when it comes to positive psychology, right? So it makes sense that obviously your sleep score is going to be worse. Your anxiety, depression, substance use, and post-traumatic stress scores are going to be worse. But we also see lower scores on the positive psychology. And so with the positive psychology, these are the things that we look at. We look at relationship quality for anybody who reports they're in a significant relationship. We look at workplace support. To what extent do you feel like you can trust and that you feel supported by the people who you immediately work with and your immediate supervisors? We know that working as a first responder is a great job when you fit in, but we know if you're experiencing harassment, it's a really difficult job for people to have. We're also aware that things like family and friend support are really important. Resiliency is really important. Having positive coping skills is really important, as is your overall kind of life satisfaction. And so we don't just ask these things because we want to fill up another survey and get that, but part of the reason why we ask these things is that every single one of these characteristics is directly related to the behavioral outcomes that we're looking for. And so when we look at, again, comparing our first responders who aren't sleep impaired, those ones in the blue with the ones in the black, what you can see across the board is that we are scoring significantly lower at every single behavioral health measure that we look at. As a matter of fact, even when we get in satisfaction, and we go satisfaction, everything from life in general to your physical health, to your nutrition, to your spirituality, to your involvement in community, every single thing that we asked about, our first responders with impaired sleep are doing worse. I'm going to go back to this just to kind of point this out because we're going to come back to it in a little bit. But if you look at that top bar, relationship quality, right? These are the extent to which we really feel like we're getting along with our significant other. That's the one where we're doing the worst across the board. Unit support is usually pretty good. Not a lot of our folks report that they're experiencing significant harassment in the workplace, which is great. We feel like our friends and family are generally supportive, but our relationship quality is the lowest score that we have. So it kind of brings us to the Captain Obvious moment, right? As we start looking at these things, sleep, it turns out, is really important to your mental health. And for those of you, and I don't think there's anybody in this chat right now who's watching the survey who doesn't understand that mental health is important, but you might work in departments where mental health isn't something that's recognized. And so for those folks, when we start talking about the importance of sleep, we can point to a whole bunch of other physical health concerns too, where it really shows that impaired sleep can really cause significant damage to our well-being. So one of the things that we're learning is that impaired sleep is actually one of the leading causes of cancer that we're seeing across a number of cancers that first responders test higher for. And as we get better and better at kind of reducing our exposure to toxins and having multiple sets of turnouts and using wipes on scene and doing decontamination and making sure that we're wearing our SCBA when we're doing overhaul and all those things that we're trying to, and keeping our bunker gear out of our dorms and out of our personal vehicles and all that. But one of the things that we're finding is as cancer rates aren't getting significantly better, is that it might be the impaired sleep that comes from shift work that's really kind of leading some of these changes. Not that we're not going to do all the other things to reduce our toxins exposure, but if we're just doing that and we're not addressing impaired sleep, my thought is that we can do better for our first responders. And so the one in yellow that's on there too is that maybe you have a fire chief who doesn't even really care about your physical health. Hopefully that's not the case. But think about how expensive injuries and accidents are. If you have a first responder they're on their fourth call of the night and they go to get out of the apparatus and they land on a curve, they tear their Achilles heel and they're out for 6 to 8 months. That's a huge impact. And so we want to make sure that we're doing all that we can to address sleep. Now I've got a screenshot of a book up there by Matthew Walker. I have never met Dr. Walker. I am not in collaboration with him, but I talk about his book a lot. So maybe I'll get a signed copy one day sent to me. But this is a really powerful book that I think does an excellent job of kind of taking the data on sleep, all the scientific data on sleep, and digest it in a way that makes it easy for people like me to read and kind of understand. Now, I don't recommend this book to anybody who isn't serious about considering changes in your sleep patterns, because it's really hard to get exposed to all of the data and not feel compelled to make some sort of change. Now, I know first responders are extremely busy. You don't have a whole lot of time. And so, yes, there's a full book here, but thank you, Dr. Walker, for putting together basically a Cliff Notes version of that same book. And if you're not a reader at all, he even has a great podcast that you can listen to in order to kind of figure out what are some ways that you can kind of improve your own sleep. So, probably the most kind of beneficial or kind of enlightening chapter or section of Matthew Walker's book is that he drives home the point that even if you have been chronically sleep deprived for 20 to 30 years, and I know that we'll have some people who are listening to this today who put themselves in that boat, when you are able to make changes to your sleep, even in these chronically sleep deprived adults, we see improvement across the board. And so everything from improvements in immune functioning to better fitness and recovery to weight loss, and along with weight loss, we see reductions in cardiovascular risk and all of those things. We see cognitive changes that happen. We see your immune system kind of get better and reduce risk for infections. But one of the other things that's really nice benefit is that we see reductions in depression and anxiety, and we see overall improvements in psychological and emotional well-being. And so we know that our first responders, by the nature of their job, are going to have some sleep disruption. And so we want to make sure that we're doing everything that we can to try to minimize that. And so what are some of the things that get in the way, right? Now, granted, you're a first responder, and most of you are working 24-hour shifts, and we're all compelled that when the tones go off, when the citizens of our community call 911 and reach out for help, we have an obligation to get up and go, right? So there's really very few things that we can do in order to kind of improve your sleep. When you're at the station and somebody calls 911, you're going to get up and go. That's part of the job. But there's other things too that kind of impact it too, in terms of, our cultural values and our tradition. Well, this is the way that we do things, and we're going to keep doing these things, for hundreds of years beyond now. We know that first responders tend to have a tendency to put other people's needs in front of theirs. And so it makes sense to put your own needs to sleep kind of on the back burner in order to take care of other people. We know that there's bonding that happens, right? We deploy firefighters on these wildland things, and they go on deployments to go and help in these disaster areas. And they come back and they're like, oh my gosh, we slept for 45 minutes over 3 days. And there's kind of this exchange of high fives, right? And it facilitates that bonding. And so these are all part of the things that we have to kind of overcome. If you've ever worked at a station where nobody was allowed to go to bed before midnight, because if you did, sure enough, you would cause those tones to go off. And so we have people who are staying up until midnight because they don't want to jinx their station and get a call. And eventually it becomes this pattern or this habit. And we also have to factor in, that we don't always make the best decisions. And so, whether we're staying up late to watch World Cup soccer games, or as my wife yelled at me for, staying up late to watch a curling event between two countries I couldn't find on a map in the Winter Olympic Games in Tokyo several years ago, right? Why am I staying up and watching curling? Well, we don't always make the best decisions. And so we know that's part of it too. And so, when we think about it, how are we actually going to make some meaningful changes? Basically, there's two tacks that we want to take. Is one, we want to figure out, okay, what can we do as a particular department, or what can we do as a service in order to kind kind of do things. And then secondly, what are things that we can do as individuals? And when we look at what are some department-wide initiatives, obviously the holy grail on that is that we look at shift schedules. And for those of you who are watching online, I'd love for you to put into the chat, although I can't see the chat, what time you do shift change, right? Are you on a 24/48? Are you a 48/96? Are you working a 12-hour demand apparatus? Are you a law enforcement professional who's working days for a series of times, and then you go to mids, and then you go to overnights in order to kind of try to balance out that imposition? But we know that there are some things that can really impact things. Shift start time is obviously the most obvious thing that we look at. I'm really lucky that the fire department that I work for does a shift change at noon, which although to be completely honest, that change did not occur because we were worried about behavioral health and making sure everybody was well rested. There were other factors that came into play. One of the things about a noon shift change is that there is nothing structurally in place that means that our first responders have to show up to work tired. Our EMS agency has several different start times that people can bid into, whether you're working at 10 a.m. to 10 p.m. Demand truck, we have some reverse 24s where people start shifts actually in the evening, and then they work their 24s, and then they go back and get off the evening, and they have an opportunity to go home. But shift start time really has an impact. And so you can imagine those of you who work in departments where the shift change starts at 7 a.m., which means that we need to usually be there by about 6:30 in the morning. And for those of us who have a long commute, it means we probably need to leave the house about 5:30, so we try not to get stuck in traffic, which means we probably need to wake up at about 4:45 to get all of our stuff organized and our food ready to kind of go. And what ends up happening is that we have first responders who are showing up to work already tired. And then we have you work a 24-hour shift, and we're at the mercy of our citizens, and we're going to respond to every call we get. And sometimes we get a benefit and we only wake up once or twice. Other times we're up most of the night. And so now we're looking at 2 nights of impaired sleep. And then we do something where we'll wake you up at about 6 a.m. in the morning so that you can do your station duties and maybe clean the toilets or mop the floor, so that when your relief comes at 6:30, we can send you home on 2 days of deprived sleep, now in the middle of rush hour traffic to try to make it back to your family, or for several of our folks to try to go make it to another job. And so shift start time is something that I think is really very important that we talk about, and that we see. If we believe the data that impaired sleep is our biggest behavioral health issue, are there things that we can look at? We know that other departments, a lot of departments work on a 24/48 shift. Some work on a 48/96. There are some departments like DC where they work on a 24/72. Our EMS, one of the options for our providers to work is a 24/72. Other people work 24 on, then 24 off, then 24 on, then 24 off, then 24 on, then 24 off, another 24 on, then they get 4 days off, right? So there's different kind of schedules. And so one of the things that we really have to pay attention to is that our first responders have built their lives around these schedules. And so you can't just go in there and make changes. But it's something that we really want to make sure that we're looking at. If we genuinely care about our first responders and we genuinely care about their behavioral health and their physical health and their relationships, what are we doing to actually look at that? And so we know that again, shift schedules are the holy grail, and we're not big fans of change for that. But there's some other department-based initiatives that we encourage our departments to kind of look into. First and foremost, we want to make sure, to what extent do we have appropriate staffing levels? And if your department is like most of the departments that I work with, staffing shortages are real. We've had a lot of first responders who have left the field, either because of COVID or financial situations, or it's just they got to the point where it's time for the natural retirement. And we're seem to be having a more difficult time kind of filling those slots. Do we want to consider term limits in high call volume areas? We have some stations here that are really, 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 really busy. And our folks who work in those stations for, 10, 15 years, it can have a huge impact on their well-being. And eventually, these folks will decide that they've had enough, they've served enough time, and they decide to promote, and they move to a different station. And that's the thing that I hear consistently is just how much better they feel, and how much better the relationships are. And we get contacted by the significant others of people who are saying, now that my first responder is sleeping, our relationship is a whole lot better. Does it make sense to alternate stations by call volume? If we have a broad array of busyness across the municipality, or the service area that we provide coverage for, does it make sense to alternate where you're working the busy stations for 3 shifts, and maybe you get a night at the slower station after that, or do you do 3 on 3? We really want to encourage our people to be considerate of that, and to be really creative to try to figure out what makes sense for them. Are there policy changes that are in place that kind of prevent us from making sure we're taking care of ourselves? Do we have permission to do a safety nap if somebody is tired? Are there restrictions on that? Are there limits on training in terms of how late we can train to make sure that we do things down? Do we want to make sure that we have things like a station wind down time where we can kind of encourage that maybe at 10 o'clock at night, we kind of turn off any CEs, or we just kind of do that, and it gives us an opportunity to really kind of wind down. And then really, what are some of the structural and environmental changes that can come in place, whether we're looking at temperature, light, sound, private rooms, and unnecessary tones. And in our agency, we used to do shift change at 7 a.m. And when we moved to a noon shift change, we didn't get rid of the 7 a.m. tone, which was a huge source of frustration for our field personnel for years and years and years. And so by being able to get rid of that 7 a.m. tone, we were actually reducing the number of awakenings that we were having across the city, no matter how busy our folks were. And so here we are offering all these changes, but we know change sucks, right? What's the one thing that first responders hate more than the way things are? And the usual response that we get is change. And so change is hard, and change has to be purposeful. It has to be intentional. It has to be goal directed, and there needs to be buy-in from everybody before we go and we start changing people's schedules. Because I don't care how crazy somebody's schedule is. I guarantee you that you have first responders who have worked a secondary job around that, who have found nanny and daycare who can work around that schedule. And so we can't just go in there and make these willy-nilly changes, but we really need the departments to kind of work together with the executive teams, as well as the associations and the members themselves, to figure out what makes the most sense in order to make sure we're taking care of our folks. So we talked a little bit about, what are some of the things that the departments can do, but the good news is that you as an individual, we want to empower you to make some changes too. For those of you who have a child, or previously had a young child, and we talk about bedtime routines, I get a lot of information. A lot of parents incorporate a very, very specific, consistent bedtime routine for their kids. I can tell you for my youngest 8-year-old, he usually gets a little bit of a warning that it was time. He goes and he takes his vitamins. He uses the restroom. He takes a shower. He brushes his teeth. His mom reads a book to him, and then I sing Margaritaville. I really do. That's the song that we sing. And we do this same routine every night that we're home, and we have the opportunity to kind of do this. And not surprisingly, the reason why we do this regular routine is that it actually takes advantage of what we know about neuroscience. And that when you do a same routine over and over and over again, we're basically Pavlovian dogs. And so if we can do a regular routine that lasts about 20 to 30 minutes, our brain will actually start producing the chemicals that are associated with falling asleep when we start that routine. And so it's a really powerful tool that we can have, that if we do the same thing for about 20 to 30 minutes each night, we greatly reduce the amount of time that we spend awake in bed. We know that it's important to have a regular sleep schedule, especially at home when you can control it. We encourage people to try to go to bed at the same time and try to wake up at the same time, even if you didn't get a good night's sleep the night before, because again, we're trying to get our body into a rhythm that makes sense. For those of you who are thinking about making changes, and you normally go to bed at 2 o'clock in the morning, and you go to bed at 11 o'clock tonight because you're like, I feel empowered to go and do this. Guess what? you're going to lay in bed for a couple hours and you're not going to fall asleep most likely, because the evidence suggests that if we're going to make these changes, we need to do it gradually. And so to start with a 15-minute reduction and to try to space those out every 3 to 4 days. So if it's normally 1 o'clock, maybe tonight you try 12:45 and you do that through the weekend, and the next week you start at 12:30 and you gradually walk your way back, and that's where we see the greatest effectiveness for that. We know, and this is one that I always personally struggle with, to try to reduce the amount of time you spend awake in bed. They say try not to go to bed before you're sleepy, but you said, Mark, go to bed at the same time every night, right? And so sometimes there's a little bit of contradictory information. I have a hard time with this one because if it's a difficult time for me to fall asleep, the last thing I want to do is to get out of bed and kind of start that process over again. But the data suggests that it's actually really effective, that if you find yourself ready to sleep, all the distractions are put away and you're up for more than 30 minutes, they encourage you to get out of bed and kind of start that process over again. And basically what we want to do is we want to make sure that we're not doing things in bed other than sleep and what we call consensual adult activities. My wife is famous for, and I can say this because she's never going to watch this podcast, I doubt. But she's famous for dropping kind of bombs when we're about to fall asleep. For example, hey, my mom is thinking about moving to Texas and living down the street from us, and then she falls asleep about 2 minutes after that. Or hey, my sister and her kids are going to move out and stay with us for 3 months during COVID because California has greater restrictions than ours do. Or hey, we need to talk about finances, right? So to try to avoid having these difficult conversations when you're in bed. Something that a lot of folks don't like to hear is that it's really important to minimize our napping. And the reason we want to minimize napping is that the more you nap during the day, actually the harder it is to fall asleep. And so this paradoxical effect on nighttime sleep happens because if you get into the REM cycle of sleep, you actually reduce your sleep deficit. So for those people who like to take safety naps, the best data suggests, let's try to keep it to 45 minutes or less. And ideally, make sure that you're napping at least 6 hours or more than before you go to fall asleep. We think it's really important to minimize and kind of time your use of substances that impair sleep. Alcohol is on there. I'm a big fan of alcohol. I'm an alcohol researcher by trade, and despite my fondness for alcohol has consistently lied to me, and that it has not made me a better dancer, and it has not improved my sleep. No matter how often I've given it the opportunity to work. And so alcohol, even though it's a depressant, it acts as a stimulant in the regions of our brain that are associated with deeper stages of sleep. And so not surprising, a lot of people who are struggling with post-traumatic stress, sometimes they'll report that they will use alcohol as a way to, what they report, get a good night's sleep. But what they're talking about is that they don't have nightmares. And that's because you're not getting to those restorative stages of sleep. And sleep aids are have an asterisk there because one of the biggest predictors that we have of insomnia is regular use of sleep aids. And so because our brain gets used to the certain amount of chemicals that need to be implemented in order to fall asleep, when we start relying on medication to do that, our brain stops producing those chemicals for us. And so a lot of people will develop insomnia if they're using sleep aids regularly. Exercise is really important, but make sure you do it early in the day. And again, they recommend more than 6 hours before you fall asleep. Eating is an important thing, especially when you wake up in the middle of the night and you have to go out and perform a lot of services, whether it's providing patient medical care, dealing with vehicle extractions, or putting out a fire. But so they recommend that if you have a difficult time going to bed on an empty stomach, to eat a small snack for that. Sleep environments are really important. And when we talk about sleep environments, the three things we really look at are light, temperature, and noise. We want to control the light exposure, whether that you're using blackout curtains before you go to bed, especially for those of you who have to sleep during the day because you're working nights. That's a big thing. And then when you wake up in the morning, you're ready to get started. We really want to expose you to bright lights, ideally the sun, in order to kind of get your circadian rhythms on track. Body temperature is a big thing, right? Most of us like using fans, and fans do a couple things. One, it provides white noise to kind of drown out some of those things, noises, especially box fans. The other thing it does is it provides us with consistent temperature. So if the air conditioner is going on and off, or the heater's going on and off for our friends in the Northeast right now, it makes a big difference. And so to make sure that you're able to kind of take care of yourself. One of the cool little body hacks is when we fall asleep, our body temperature naturally declines. And so for those of you who take a hot shower or hang out in the hot tub or take a nice bubble bath and read a book, if you do that right before you go to bed, as you artificially increase your temperature with the water, as your body temperature starts decreasing, it actually tricks your brain into producing some of those chemicals that they put us into those deeper stages of sleep. So that's a nice little body hack. And ideally, especially for those people who struggle with worry, we want to make sure that we're turning off our sympathetic nervous system. And as we all know, our sympathetic nervous system is triggered by our response to a perceived threat in the environment. And that threat doesn't have to be real. That threat can be, oh shoot, I forgot to do this, or man, I've got a test the next day, or I'm studying to try to promote, or you're worried about finances, or you're worried about kids, and any of these things that worry you, it activates your sympathetic nervous system. And Mother Nature is really smart, and she knows that if you're experiencing a threat, a physical threat, she doesn't want you to get a good night's sleep, right? Because she wants you to be alert to changes in your environment. So doing things like relaxation or parasympathetic breathing, where you're able to turn your sympathetic nervous system off, can be a really effective way. I already outed myself in terms of my unnatural interest in watching curling during the Winter Olympics. But sometimes we want to make sure that we're making good personal choices. And the most effective strategy for getting improved sleep is really to go to bed earlier. And so, Netflix has made it really easy for us to watch lots and lots and lots of episodes of things, but we want to make sure we're really taking good care of ourselves and making good personal choices. And then finally, if our first responders are doing all of these things and they are practicing proper sleep hygiene, and it's still not working, then we want you to reach out to a professional. And whether it's a medical professional to be evaluated for some sort of sleep condition, whether it's snoring and sleep insomnia. If you're having urinary issues and you're getting up 6 times a night, well, that's probably not a psych issue. We want to make sure that you don't have any kind of potential bladder issue going on. So go and see a urologist. But we want to make sure that you're really kind of taking care of yourself from that. So moving on, and we're kind of running towards the end, I just want to show a little bit of kind of some of the data that we get. And so one of the questions that we ask our first responders is, hey, in the last year, have you reached out for help? And not surprisingly, 64% of our folks report, I'm fine, there's no need for treatment. About 15% report that they had difficulties in the past, but they certainly didn't think about reaching out for any kind of behavioral health assistance. About 6% report that they are experiencing difficulties and they have thought about it, but they haven't done it yet. And about 16% of our folks report, yeah, in the last year, I've actually reached out for help, which is really great. And not surprisingly, what we see as the number of positive screens increases from none to 1 to 2 to 3 or more, we see a reduction in the number of first responders who are saying, you know what, I'm totally fine. But even still, 1 in 5 of our first responders who are screening positive for 3 or more screens they're not recognizing these difficulties. The other thing that's kind of nice to see is that as the number of positive screens increase, we see a high percentage of our first responders report that they're actually going and getting help, which is great. But still, even then, we're looking at less than 40% of our first responders who are screening positive for 3 or more of these 5 behavioral health conditions are actually getting assistance. One of the ways that we see the benefit of this assessment that we've created and the feedback that we provide and the education and getting people connected to resources, we see these people who at year 1 are screening positive for stuff, but they don't recognize the symptoms. We see them start to move down to the people where at least they're starting to think about it. The other thing that we see is we see these people who are recognizing they're having difficulties, but they're not getting help. We're starting to see those people actually go and get help between year 1 and year 2. But one of the things that we did is we asked these people who say, yeah, you know what, I'm experiencing difficulties, but either I haven't thought about getting help seriously, or I've thought about it but haven't done it yet. We asked them what's getting in the way. And these are the top barriers to behavioral health care that we're seeing in our national sample and first responders. And the top 2 are really important for us to pay attention to because this makes a lot of sense. And these are some of the issues that if you're a member of the peer support team, or you're a behavioral health professional, or you're a chaplain, or you're either a formal or informal leader in your department, whether you're on the chain of command side or even on the association side, these are things that we really want to make sure that we're addressing. The belief that it wouldn't help, absolutely. Why am I going to go and talk to somebody and talk about some of the most frustrating parts of my life if I don't think it's going to be a benefit? And so we want to make sure that we're providing education that the treatment actually is available. The third most common gets to a very real barrier that we have to address. And this is where we put some of the initiative on the department and some of our insurance agencies. How can we make behavioral health care more affordable for those first responders who are recognizing they're having difficulties, who are thinking about getting help, but they're not yet? You know, a third of the people report that expenses are a primary reason why they're not getting the help that they need. In addition to those things, the next 6, or excuse me, the next 5 are really related to some of these stigma factors. And I think we've done a pretty good job as a community of first responders to kind of tackle the stigma, but certainly it's still part of what our first responders deal with when they think about going out. The next 2 are really kind of more of these pragmatic issues. It's difficult to schedule. I don't know how to get help. A lot of our departments have great resources that nobody knows about, right? And so what can we do to make sure that we're making those resources available to folks? And the last 2 are really related to, you know, are there factors in our agency that are really discouraging us from getting help? Either the leaders actively discourage use, or we have a significant other, family, or a friend who's not supportive of behavioral health care. So ultimately, the question that you should be asking yourself is, you know, if you're thinking about incorporating a behavioral health check-in into your physical, which is part of what we're supposed to do for NFPA 1582, we want to make sure that we're actually doing something that's effective. And when we evaluate the effectiveness from year 1 to year 2, one of the things that we see, as I mentioned, we see increases in awareness of behavioral difficulties. We see increases in treatment seeking. And for those people who are seeking treatment, we're seeing reductions in both symptoms of behavioral health disorders, as well as positive screens for disorders. One of the things we've also realized is the effectiveness is really increased when it's reviewed during an annual physical. And so assessment, education, and feedback are really meaningful interventions. I'm presenting on this slide the results from one of our departments. This was their depression slide in terms of their score and how they're doing. This is one of our most recent departments. They just started with us in February. And not surprisingly, because again, nationwide, we see about 2% of our first responders report that in the past year they've contemplated suicide. But I want to kind of highlight a really positive interaction that happened. So this department, they're a small department. Our services are really inexpensive. So we presented basically this presentation to them on Friday. On Monday, they decided they were going to do the assessments. On Tuesday, we got their list of resources and got their emails so we can get them in. On Thursday, their department sent out kind of an introductory email. On Friday, we sent out the surveys. And here's a text I got on Friday night from their physician. And so as she was preparing to do the physicals and kind of familiarizing herself with the reports, she says, I was perusing the first handful of completed surveys, and one person screened positive for severe insomnia, major depression, post-traumatic stress, and suicidation. I know the member well, so I called to check in, and it was very well received. So literally from 1 week of learning about this to the next Friday afternoon, they had had a positive interaction with one of their folks, and they were actually able to successfully get this person into treatment. Now, this just happened a couple of weeks ago on Friday, February 3rd, as the screenshot shot shows. But the goal is that this person's going to be able to get better and be able to keep their position within the department. Obviously, that's a huge component of what we do and making sure we're protecting privacy. But ultimately, we want this person to get to a better spot. So just kind of in summary, behavioral atypical is really prevalent in first responders. If we stick our head in the sand, we're doing a huge disservice, right? We know that firefighters and other first responders are at increased risk for cancers. We know they're at increased risk for cardiovascular disease. And so we have an obligation to deal with it. Same thing for behavioral health. The evidence really seems to suggest that as a starting place, sleep might be where we want to go. And so sleep tends to be a primary driver of behavioral health outcomes. If you work for a department that doesn't care about behavioral health, well, great, it's related to physical health as well. We know that the data shows that when we treat even chronically sleep-deprived individuals, everything gets better. And we can look at both department-wide interventions in terms of things like policy changes, and do we look at shift start time? And we can also encourage changes in individual first responder. And just like we talked about earlier, that physical health is more than just the absence of cancer, behavioral health is more than the absence of symptoms of distress. And so relationship quality is something that we really want to pay attention to. I can tell you as a psychologist who's worked with first responders for going on 12 years now, the number one referral source is the significant other of the first responder. And so we want to make sure that we are addressing these things, that we're providing couples counseling so that we can make sure that we are taking care of our first responders, not just when they're at work and they've got the patch on and they're providing services to the community, but when they're home as well. The nice thing is that I think this also provides opportunities for our peer support teams and our chaplains to really be proactive instead of reactive. What kind of educational things can we provide, right, in order to make sure that things are going well? Obviously, if there's a difficult call, we want to send our peer support out there. We want to reach out and make sure we're taking care of things. But if we're only reacting to difficult calls, we might be kind of missing the boat. First responders, you guys are really great at a lot of things. There's not a single problem that I've ever come up with that I can't reach out to a first responder and get at least several different options on how to do it, whether it's plumbing, electrical work, taking down a 45-foot tree that we lost half of with the winter storm we just had. But you guys are really good at a lot of things. One of the things you're not really good at is recognizing some of the more subtle symptoms of psychological difficulties. And so it makes the importance of doing these screeners really, really, really critical, right? And so these things come on slowly, and it's hard to detect these things from one day to the next. And so we want to make sure that you guys are following up and that you're doing a check-in every year. And finally, barriers to seeking help remain, even for first responders who recognize they're experiencing difficulties. And so as a service industry, as departments, we want to make sure that we're identifying and removing those barriers for moving forward. One of our departments, when they went through it, they saw that stigma was, for that particular department, the stigma and worrying that they were going to be treated differently by their superiors were really their top things. And one of our chiefs, when they got the results, said, basically that's garbage. That's the exact opposite message that I want to send. And this chief decided to work with their public relations office to create a video that he made talking about his own challenges with behavioral difficulties and the effectiveness of the services that he received. And he put it out to their membership. And the next year when we did the assessment, stigma went way down, right? That wasn't the reason why people weren't doing it. And then the reason that came up was really, I don't know how to access these resources, and it's really expensive. And so the chief for year 2 was able to take that data to go to their funding sources, and they actually just hired a half-time clinician to be able to provide services for their folks free of charge. And so again, the goal of this is we want to make sure that we're doing all that we can to take care of people. So, ultimately, what is change? What's worth making a change for? Change is not easy. but change might be important for our folks. This is the end of my PowerPoint presentation. For those of you who made it all the way, congratulations. I'm sorry for talking so long. If you haven't seen this episode of The Office, this is the fire drill, which is one of the best episodes of all time. And so Dwight Schrute said, it's my own fault for using PowerPoint. PowerPoint's boring. So thank you for sticking in. For those of you who are interested in learning more about this is a QR code where you can go to our website and you can take a free assessment to kind of drive through and see how these assessments kind of work and what kind of feedback you get. Please rest assured that this goes into what's called the dummy database, which means it doesn't go into our national database, and it deletes itself after I think it's like 2 weeks or 30 days. And so you can feel free to answer questions based on the most difficult part of your career, or if you have someone in your department that you're worried about, how you think they would answer these questions, so you see what kind of feedback they would get. But I'd really like to thank you all for signing up for this and for caring about not only your own behavioral health, but the behavioral health of all first responders. And if there's any questions you have or anything that I can do for you, that's my contact information on there.
So Mark, as the moderator for this and the host agency for this, we usually run an hour. We haven't lost many participants. We're going to keep plugging along. So the first thing I want to touch on, and you blew me away when you told this to me during our podcast. If you go out and do an assessment for the fire department, what's the cost per individual for you to do your assessment?
It's $35. And so it's less than a copay.
Do you hear what I'm saying, folks? $35 a person to have. And this isn't an advertisement for his company. I'm just telling you, facts is facts. $35 to have his company come out and do these assessments in your department. Someone asked the question earlier. Now, I want to go back to something you asked earlier, and a lot of it popped up in the chat. And we're not going to discuss these, but you asked a question about shift work with others.
Mm-hmm.
I got to go back here and find them now. Okay.
I'm gonna stop sharing so maybe I can see the chat too.
Okay.
So I'm gonna do that.
All right. So let's see. I gotta go back here and find them quick.
Oh, we even have 4 questions. Thank you, guys.
Yeah, I'll hit you with the questions here in a second. I want to go back to some of these dates or shift changes. I know the first military base I worked on in the fire department, our roll call was at 06:55.
Oh.
And we worked 24 on, 24 off. So here's some of the shift changes. Here's 4896, 8 o'clock shift change, 6 a.m., 8 o'clock, modified Kelly schedule, 2448, 7 o'clock, 7:30, but most come in between 6:45 and 7.
Yeah, because 7:30 you're gonna get stuck in traffic if you've got to be there at 7:30.
0700, 2448. Now, so obviously these guys are on the career side, okay? Here's somebody that's up at 3:20 to drive an hour to work. So, all right, so we have some career people put their shifts in here. Mm-hmm. I spent most of my career, I was in a career department, but I've spent a lot of my time in a volunteer side as well. Okay, so I work my 8, 10, or 12-hour shift. I come home from work, working wherever I work.
Yeah.
And I sit down and have my supper. And 10 minutes after I have my supper, the pager goes off and out the door I go. I get home 2 hours later, clean myself up, get ready to go to bed, and the pager goes off again. And then it goes off again in the middle of the night. And then I get up at 6 o'clock the next morning to start my regular full-time job all over again. Okay. So
and you're not getting compensated for it.
I mean, right. So do you have any suggestions for volunteer departments on how they might be able to help with the sleep deprivation part of this?
Yeah, so that's a great question. And again, there are some real challenges to what we can do in the nature of the job. And it tends to be that it seems like a lot of the emergencies happen in the middle of the night, right? And so there are some real restrictions to when you actually, when the tones go off, when the pagers go off, we expect you to get up and go, right? But one of the things that we talk about with the volunteer agencies is a lot of our volunteers are on the pager, whether they're on call or not. right? And so if everybody is getting woken up, even the ones who aren't necessarily expected to respond, and they're just in case there's a second alarm that's called, or we don't get responses from the first ones, what are things that we can kind of minimize the impact of the sleep on that? Do we do things like, do we try to make sure that we have a strong enough volunteer force that we can share some of that load, right? It's just a really, really difficult thing. And I know, we struggle to get really good, dedicated volunteers, and the ones that we have are absolutely amazing. But to get people who are willing to make that commitment and to be there. So our volunteers are doubly challenged because they're providing all the same benefits to us, but they're not getting the benefits of going back to the station and going to sleep. You're going back home.
So something I know a department in a county 2 or 3 for me several years ago started to do is that they started, you didn't have to be at the station, but they had a dedicated group of people that worked, for the lack of a better term, a duty crew overnight.
Mm-hmm.
And they had a chief that was the duty chief overnight. And for things like automatic alarms and that type of stuff, they made the decision based on data that they had collected, that they felt comfortable that with a lot of the calls they got through the night, they could send just that one engine with 5 people on it and that duty chief. So then the next night it was 5 different people and a different duty chief. And then when they got to the scene, if they needed the other people, it was a matter of telling the county, hey, dispatch another call. So that they took a look at their historical data, and they saw that a lot of the automatic alarm, and I know people are going to start throwing darts at me now. Oh my God, you're only responding one piece on an automatic alarm. But they looked at their data, and their data told them that they could make a pretty reasonable case for not dumping an entire fire station and calling out 30 volunteers in the middle of the night for something that only required 4 or 5 people.
Yeah.
And it worked well for them. Now, I can't tell you if they're still doing it, but I just bring that up as a way to try to give some relief to the volunteer side of the things.
Yeah.
And
by the way, it's one thing to be at a station and get woken up, but if you're at home and you're getting woken up, so is your significant other.
Right.
So might your kids, right? And so if we have both the first responder and the significant other sleep deprived and irritable, like, how do we think that's going to work out?
So I just throw that out to the volunteer community. I think there are ways that we can help eliminate some of those issues if we just think outside the proverbial box.
Yeah.
And be realistic about, do I have to have 30 people respond to the typical automatic alarm? If I know I have 5 people that are going to get up and get out of bed that night, and they're going to take the engine and go to the call, and they're easily can tell the 911 center or the dispatcher, hey, we need the rest of the troops here. And we're going to get to the questions and answers in a minute or two. But because a lot of the people we're talking to tonight are volunteers, and I was surprised to see the number of shift people here, which means we've got some career folks too.
Yeah.
So, all right, let's get to the questions here.
Great.
If you can only ask a limited number of questions to survey personnel on mental health, what would you recommend is the best questions to ask?
So I come from a world where we do these like crazy long assessments, right? And so one of the most important things that you have to do, and that's one of the benefits of doing the way that we designed it, and we've got a guy who's like some computer genius. I call it magic. I don't know how to do it, but that kind of choose your own adventure part is we try to only ask questions that are relevant to the individual, right? And so, for example, the first question we ask on alcohol is, have you used alcohol in the last year, right? Because if the answer is no, I'm not going to have you answer all the questions on alcohol. We're just going to do the follow-up about the reason why. And I saw someone in the chat, 35 years without alcohol. Congratulations. So you have to balance kind of fatigue of it with something that's meaningful, right? And so one of our chiefs, he had just happened to have his physical with his regular doctor, like the week of when we actually talked with him, and he said when he did that, and there was a long question about medical history and heart disease and stuff like that, and there was a question about do you feel psychologically well, yes or no, and do you want to kill yourself, yes or no? And that was their medical office's level of behavioral health check-in, right? And so that wasn't very meaningful for that, and that wasn't their fire department check-in. That was their level. So to me, you should really only ask questions that are relevant to the individual, right? One of the things I didn't talk about, so these screeners are all designed to be, okay, in the last 2 weeks, how are you doing? In the last 2 weeks, in the last 2 weeks. What we also ask is we say, okay, was there a period of time in the last, after we asked in the last 2 weeks, these 9 symptoms of depression, then we say, was there a period of time in the last year where things were significantly worse? Because I might just be mildly depressed now, but 6 months ago, I was thinking about killing myself. And turns out that information is relevant. So when they answer, yes, there was a period of time, then we go and we ask follow-up questions about that. And so we really try to tailor it so that people feel as though they're only asking questions that are relevant to them. And it depends, right? So if I fill out all these questionnaires and then I don't get any feedback on it, then I'm going to feel like you wasted my time, right? But if you're actually providing some meaningful feedback and, hey, let's go over your scores and let's see how you compare to other first responders or to other people in your department or to the general population, if those are the only norms that you have. And what can we do about this? It seems like your anxiety's kind of increased a little bit. What's going on? I think if you ask questions, you have an obligation to try to provide something meaningful to the first responder, because first responders are busy. They don't have time for stuff that they don't get any benefit out of. But if they know that you genuinely care and you provide feedback, then I think it's okay. So I don't think it's the number of questions. And NFPA 1582 says, ask for depression, ask for post-traumatic stress, and ask for substance use. Those are things that you have to. As you see, about 25% of our folks screen positive for worry-based anxiety, and more than half screen positive for impaired sleep. Based on the data that we had, every single department around the country that we've done, impaired sleep is the biggest issue. And most people are motivated to make changes with their sleep. And so I would suggest you do at least what NFPA asks, and that you also ask about sleep at a minimum.
So this question was in Q&A earlier, and then it got removed, I think. But the question, and right after he asked the question, then you mentioned the word suicides when the question disappeared. But okay. I want to ask the question or try to remember it. And the question was, how does sleep deprivation lead to, or does sleep deprivation lead to more ideas of suicide?
Yes. So one of the most effective and inexpensive forms of torture that's ever been used is sleep deprivation. Right. Okay. Like sleep deprivation is considered psychological torture. And the reason why is that yes, long term, it has all sorts of effects on our body, but even short term, it can have huge effects on our emotional and psychological well-being. Right. And so when we see increased risk for depression, what we oftentimes is we see people who feel the situation is helpless and it's not going to get better. Right. And so when people are in these chronic situations and they've tried things and the things they've tried have been ineffective, or they've reached out for help and they haven't gotten the services they deserve, that's when we see kind of increased risk for suicide. But impaired sleep kind of leads to this thing. So then we see increased risk of depression, increased risk of anxiety. We become more irritable, so our relationships suffer, which makes our lives worse. And now we're sleeping on the couch, so we're not getting as much sleep, and we start drinking more, and it's all interrelated on it. All right. And so I don't know off the top of my head any data that says if you deprive someone for this amount of sleep, we see an increase, this percentage increase in suicidality, but it's all interrelated. All right. So next question, do any peer support CISM teams partner with your group? So what we do for each department, because again, these are supposed to be designed as part of the annual physical. When we meet with each department, one of the things that we do is we spend time figuring out what are your local resources, right? What are your trusted resources? Do you have a clinician in your department? Do you have a clinician in your community who works with it? How do they access the peer support team? How do they access the chaplains? If there's a special CISM trained team, either with their department or with their organization, are there trusted clinicians in the community who take their insurance or don't take their insurance but do private pay? EAP, we spend a lot of time with each departments because at the end of each of those individual reports, you get a list of your local resources with phone numbers, web pages. We're trying to figure out how to put a QR code in there so people can just can do that. Websites, all sorts of stuff, because the whole goal is that if somebody's struggling, we don't just want to tell them they're struggling. We want to give them that next step to how can I get connected to resources. You know, we're based in Texas. I'm licensed in Texas. We're in 15 different states. I can't provide clinical services in Virginia or Colorado or Florida, but what we can do is we can get you connected to those trusted resources there.
Okay.
So that you don't have to go and do that extra step. It literally shows up there.
Next question is from Ian St. John. How does your group interface with the IAFF to quell concerns over privacy and feelings of being removed from duty?
Another great question. And I also shout out, I think it was Ian who put the liars in there. So I saw that in the, I think I saw that was you. So, so we have a pretty good relationship with IAFF. Back in I want to say it was 2019 because it was pre-pandemic. They invited us to go out and talk to their behavioral health experts and to show them what we were doing. And although IAFF doesn't officially endorse things, the feedback that we got from the room was nobody's doing this as well as you guys are, and you're not charging enough money. Now, that is not an official endorsement at all, but I can guarantee you the IAFF is a huge proponent of behavioral health, right? And so they're never going to endorse a single company or single way, but they want. The IAFF and the IFC, as part of the WFI, have really pushed to make sure that behavioral health is included in the annual physicals. They're a driving force behind the work the NFPA 1582, the NFPA did in 1582 to get it included. The IAFF had great representation at that meeting that I met you at, Ed. And we're actually presenting at IFC, and we're going to have 2 IAFF representatives at our presentation at IFC, because they're saying that this is something that really needs to be done. And again, not an endorsement of this particular company, but they recognize the need. And in answer to your larger question about the privacy and the security, we treat this the same way that we do the blood test results, right? And so the only person who has access to the information is the designated medical provider for the department, and it's under the same protections for that. If we have somebody lose their job because of this, we have really messed up, right? The goal of this is to help people save their jobs and to help people extend their careers by getting the help that they need. And so
Okay.
our entire focus is on taking care of and protecting people's privacy.
So Vaughn Butler has a question. When is the ideal time frame to initiate CISD on that topic? Now, I'm not sure what he means by that topic. Vaughn, if you're still with us, if you can, and I'll go to your next question, and maybe you can clarify what your question is with the first question you have. His next question was, you mentioned earlier how shift setup affects is. Do you have a preferred or recommended? IAFF puts a lot of emphasis on 4896, provided it's appropriate for the call volume.
In addition to call volume, I think you also have to make sure that you are appropriately staffed, right? You have to be really appropriately staffed, because if you are not, then you have a lot of situations where people are being required to work 72s, which to me seems really kind of very dangerous, no matter how, you know, and there's exorbitant situations, right? We just had the ice storm and people got stuck here and worked for days at a time. And, you know, we have people, I'm sure, on this chat who have deployed to disaster zones and have done that. But I think you really need to be well staffed in order to pull off a 72, and then able to fluctuate based on that. And in terms of my preference, I work for a pretty busy organization, and so my focus is always going to be what's on the best interest of our first responders. We're actually one of our departments in Illinois. They have a great setup, and we're actually use this to get the data on. But they do they have unlimited trades, and so some people have arranged their schedules for 24/48, and about half the folks have arranged their schedules for 48/96, and they're going to let us know who those individuals are. We have to get their permission from the individual first responders, but we're going to actually be able to see within the same organization, controlling for call volume, who has the better mental health outcomes, the 24/48 and 48/96s. So it's a smaller department. They're only about 130. Which is actually pretty big compared to a lot of departments. But so our sample size isn't going to be huge, but we're going to be able to follow this down the line to be able to see that.
So Ian St. John hits us here. Does your group provide assistance with grant opportunities? Now, so you don't do grants, but I'm going to assume that if someone gets a SAFER grant, that they could use that grant money to incorporate these screenings as part of and use the grant funding to pay for the screenings.
Absolutely. And what we do is we can provide some of the national sample data in terms of the justification for, why should we measure worry-based anxiety? Well, it turns out about 25% of us are screening positive for it in order to do that. The other thing that's happened is one of our initial departments, they're a small ESD, about 120-ish the first time. They took the assessment. They've grown a lot since then, but they took the data that they got from year one and then used it for a SAFER grant, and they were successful in getting that. So 120 times 35 was their initial buy-in, and they got like a $300,000 SAFER grant or something like that.
Vaughn Butler, do the screenings require physiological professional use, or can they be incorporated into annual physicals or performance evaluations?
They're supposed to be incorporated into annual physicals. And so a big part of what we did, and I showed a couple pictures of it, but we made it really easy to interpret. And so we use color coding and scores and like the score interpretation range. So it's really designed for medical providers to review during the medical assessment. Now, some of our departments have decided to have a behavioral health person. So they go to their medical physical, they get their blood test results, they do their physical, all that stuff, and then they go and they talk to a behavioral health professional. One of our departments who didn't feel like they were utilizing their EAP properly, they actually had their EAP provide all the results for them. And so there's different ways to do it, but it's designed, the results are designed to be interpreted by a nurse practitioner, PA, physician, or behavioral health professional. And in each of the first responders, they actually get their provider report too, so they can take it to whoever their provider is, especially if they're not getting department physicals. So they can take that information.
We're going to move to the last question for the evening. Again, it's from Vaughn Butler. Can you see it okay, Mark?
Yeah. The relevance?
Yeah, relevance is another concern. Can you see it okay? You want me to read it?
So it says, relevance is another concern I had regarding the questionnaires. They seem sensitive, but how specific are they for only clinically significant symptoms? What kind of threshold exists to differentiate a typical everyday mild depression versus something chronic or clinically concerning? So that's a great question. And so all of these assessments at their base are really they're the gold standard screenings that are used in medical offices. As a psychologist, I'm a little biased towards some of our more precise instruments, but a lot of medical providers aren't as familiar with those. So we wanted to use things that again could really facilitate those medical outcomes. I always tell our chiefs that I think our percentages of people who screen positive are low. And so because we know that we have some people who are black helicopter enthusiasts and they're concerned about their job security, and so they might not answer the questions honestly. But the fact that we're getting that percentage of people who are screening positive is important. We are not diagnosing anybody with that, but what we're trying to do is we're trying to raise awareness, and we're trying to catch things earlier on, so that they can kind of treat these issues before they become problematic. So they're certainly picking up on things. And again, their scores are based on how they answer the questions, and then we're comparing them to again our national sample average, so they can really see how they're doing that relative to that. But kind of our whole goal is that we get people to be thinking about these symptoms, like my client I mentioned during the talk, who came in yesterday who's been on testosterone for a couple of years, and he was using testosterone to treat depression, mild depression, which he didn't really recognize. And so, even though the blood test came back and he was within the normative range, they put him on testosterone because he was reporting difficult with fatigue, not being really motivated to work out, and just not really enjoying kind of his workout stuff. And there were some sleep things in there too. So if we can raise awareness of it, and even if people don't feel comfortable answering the questions honestly, which in time I think they will, for those people, once they realize no one's losing their job, by looking at the questions, by answering the questions, even if they put no, their graphs are going to be wrong, but they're still getting exposed to what actually are the signs and symptoms of these things. Most people don't realize that irritability is actually a sign of behavioral distress, right? And so, significant others think you're just a jerk now after working in this job, and it's probably not that they're just a jerk, but this is actually one of the signs that we see of some other things. And so we're trying to change the language where people can take care of this stuff.
All right. So one last comment here. I think it came from Vaughn, the IAFF in the 6th district, Eastern Missouri. Our whole local is really good about promoting the IAFF Center for Excellence, as well as an annual physical program, which most of our shops utilize. About 3 or 4 years ago, they started to bring in folks to provide these assessments. Hats
Awesome.
off to your local.
That's awesome.
We're going to move along here. We've gone about an hour and a half, and I'm not upset by that because apparently the folks that joined us tonight are okay with it. We actually increased the numbers of attendees as we went into the first hour. Now we've dropped off a few since then, but we're going to wrap things up here now. So Marc, I want to thank you for a very informative presentation. I'm hopeful our listeners will have a better understanding of first responder behavioral health and realize that it's more than just PTSD. We'll be uploading this evening's presentation to the Provident YouTube page. As a reminder, there'll be a very short 5-question survey at the end of the program. Please take the time to complete it. Also, Sam, our marketing guy, will be sending an email to all the attendees probably tomorrow that will have Marc's email address and the link to his website. So if you need to talk to Marc personally, you'll have the ability to do so. And his presentation will also be sent along to everybody. If you have any questions or need additional resources from today, or you have any idea for a future webinar, please email us at info@providentins.com. We'll get back to you as soon as we can. This wraps up another Provident webinar. Please join us on March the 27th at 7 p.m. Eastern Standard Time. We'll be interviewing Todd LeDuc of LifeScan Wellness to have a discussion about the total approach to addressing occupational health risk. Until then, stay safe for your family's sake.